Good afternoon, everyone. Welcome to the Global Learning Office's GLOVicariously webinar series. My name is Sarah McGuinn, and I'm a program manager here at the Global Learning Office. Thank you so much for being here with us today. Today's topic is healthcare reform and restructuring in post-apartheid South Africa, post-COVID-19 implications. Before we begin, I have a few quick housekeeping items. So this webinar will last approximately 1 hour with a presentation followed by Q&A. All participants will remain muted throughout the presentation. So as questions come up, feel free to send them into the chat. There's a chat named Q&A. So we'll collect the questions to ask after the presentation. Also, please note that this webinar is being recorded. So you're welcome to turn your cameras on or keep them turned off, whatever you're most comfortable with. And finally, we'll be launching a quick poll at the end, so keep an eye out for that. So now I have the pleasure and honor of introducing today's speaker, Professor Jacob du Plessis. Jacob is a lecturer in sociology in the Department of Sociology and Social Anthropology at Stellenbosch University in South Africa. He has extensive experience in community development practice and has served as director, board member, and chair of various community development and civil society network organizations. Jacob is also a well-known academic of the Scholarship of Engagement and has played a meaningful role in proliferating engaged scholarship and service learning at Stellenbosch University, and also through serving as primary facilitator at other South African universities, where he has been training staff in community-based research and community-based teaching and learning. He has presented papers at various conferences in the USA, Europe, China, Africa, and South America. He was more recently co-chair of the International Symposium for Service Learning, ISSL, hosted by the National University of Ireland, Galway in 2017. He will also be co-chair of the ISSL in 2021, which will be hosted by the University of Nicosia in Cyprus. He serves on the Abstract Review Committee of the Society of Third Sector Research, and he serves on the Faculty of Arts and Sciences Social Impact Committee and has been a member and previous chairperson of this committee for many years. Jacob has, of course, also been the academic director for the Northwestern University Public Health and Development in South Africa program for the past 15 years and counting. His research interests are focused on health systems, community development, and higher education, teaching and learning. Jacob, thank you so much for being here today. And with that, I turn it over to you.
Thank you so much for the opportunity to speak to you. And I also note in the audience some well-known faces of people I know, and it's fantastic having you here. So we just get my notes organized. I've got a lot of open windows on my side. My initial topic when I thought about speaking in this webinar series was to really think about the health implications of COVID-19 and post-COVID-19 implications, especially thinking about the kind of daily battle we fight to have an equitable healthcare system in South Africa. And it's very interesting if one kind of look at the historic context of health and healthcare, but going back as far as 400 years back and even longer, when you think about the settlement period, the colonial period, expansion, new eras of conflict that intersected with political interests in particular, or vested interest, and how that shaped the decisions that people made every time, and how it has a pervasive impact and a compounding impact on the health status of a nation over a long period of time. So one of the examples I would like to use, if I think about health and healthcare systems historically, is a story that comes from historic South Africa and in the 1940s. And as you know, and are perhaps aware of, is that in the apartheid government, where the National Party was in control of the country from 1948. There were definitely highly fragmented, racialized healthcare systems, which privileged the white population. So race was a key factor in shaping how the system unfolded, as well as the vested interests, economic interests in gold, the mining industry, the industrial economy, etc. at the time. But there's this beautiful story that comes from KwaZulu-Natal, in that area, of the small clinic in a place called Pulela, where it was illustrated that a primary healthcare system, if well run on key principles of equity and informing and collaborating with community members, can have health outcomes that might sometimes be totally different to the outcomes of a nation. And it was very early in the 1940s that, and in early 1950s, but late 1940s, that the Glickman Commission came and everyone studied this place called Pulela and how could they be so successful in having different health outcomes, and suggested that the South African apartheid government should implement a healthcare system of that's characterized by primary healthcare, preventative health, etc. That was not in the interest of the National Party. Of course, what they saw as their future achievement and contribution to health in South Africa was to create a private healthcare system, which was highly successful. Well, the pervasive influence of that is that today we still experience how the majority of resources are allocated to the private healthcare system, which is serving a small portion of the population, while about 35 million people receive inequitable healthcare services. And despite that, we have seen tremendous gains in healthcare. One of the other points that I want to raise in terms of the historical is also that the decisions that's made and vested interest is compounding. So if we look at the South African population, and if you look at the Gini coefficient, and you look at inequality in the country, then it's amazing to see how South Africa can be defined as one of the most unequal countries in the world. If we think about South Africa with such a wonderful constitution, a rights-based focus, where we have legislation, and some of the achievements in post-apartheid years was setting up legislation, advancing quite a great deal with thinking about the whole population accessing universal healthcare, and having achieved a lot of things in policy. But that ideal of the National Party to have this perfect private healthcare system, which renders first-class services, is a major obstacle in implementation of policy and legislation. And it remains one of the contested areas. And as I will talk to COVID-19 and the implications and effects thereof, it definitely has further implications for thinking how resources has been allocated. And it also kind of means a lot or is relevant to think about South Africa as one of the most unequal spaces in the world, because we have a large proportion in this human rights-based democratic government who are supported by our government, who who mean well. And we have a very advanced social grant system, but also a high dependency ratio in a way as a result of social assistance. So it is kind of flagged as a concern because what we've seen now in the lockdown is that thousands of people taking to the streets, standing in rows, facing further prospects of unemployment, fear, concern on the one hand. On the other hand, you have particular lockdown restrictions that makes it extremely difficult for people who live in close proximity in townships to keep to social distancing regulations, to have access to masks, etc. So a lot of resources are spent on infrastructure, etc. And in terms of social assistance being expanded by adding to people who receive existing grants and also by giving even some kind of money and incentives, but it's so little to other people. In recent months, if we do a kind of cost-benefit analysis and thinking about the future, there's been a lot of concern about the actions of government and how it's possible, what the possible long-term implications are going to be. So we're much concerned about some of these issues. So vested interests, political interests does not make a good, equitable public healthcare system, as is illustrated by the examples of the development and interest in develop private healthcare in South Africa, despite the evidence of a Pulela clinic who produced excellent preventative health and potential for policy expansion. And similarly, in the same information was also kind of presented to the African National Congress. We were active at that stage before they went into exile, and that argument kind of informed the Constitution Health Chapter in that respect. And while at the turn of around 1994, 1996, we see a very strong focus and emphasis. I mean, we all taught courses and attended courses on primary healthcare and why it's good, why communities should be involved in healthcare decision making, etc. But that shift soon turned. Now, some of the concerns and implications, and there's lots of them. I mean, one really needs hours to discuss what we observe, and there's lots of parallels between countries, is that there's concerns about corruption in tenders. So there's an investigation currently looking into what's been happening and how the procurement of contracts to safeguard safety equipment for health personnel has been awarded to family members of the current key political figures, and you see this kind of thing happening. I picked up that this is possibly happening in the States as well. So we have concerns. We know that during lockdown, we have a lot of people at home in close proximity. A lot of people are unemployed. There's a gender dimension to it. And we see an increase typically in gender-based violence. Obviously, fear and societal anxiety has a mental health dimension. That's a concern for us. The allocation of resources, especially in the country, if we look at some of the statistics, We are likely to peak by some projections in November this year, but it's unclear. So one thing that we are concerned about health governance, for example, is again the fudging of statistical data and statistical information. It appears that certain statistics are not recorded. So of all the provinces in South Africa, the Western Cape is ruled by the Democratic Alliance. And even though, so our statistics came out early, and it's also very interesting to make a few other notes about the societal response in a space that's still highly unequal and where race and xenophobia plays a very particular role in the society as well. So a lot of concerns around governance. At first, it was like being in the UK and the Queen delivering her message. In this case, it was our president who played a very paternal kind of role of calling the nation and talking to us about having to have a lockdown. We had one of the strictest lockdowns, and there was in the beginning a lot of respect for the president until some things came through in popular press. There were a lot of inconsistencies initially in communication, and there seems to be a vested interest and the different political factions. There's also ethical breaches in terms of how epidemiological data is distributed. I mean, there's very specific guidelines for ethics and in a pandemic and health crisis like this, a lot of this has been learned from previous pandemics. But what our Premier of the Western Cape did, being DA, kind of with good intent, was to breach ethics and by publishing on a very small district level research results that could have implicated where people live who were infected by the virus. Of course, that has high significance in terms of stigma. And again, this is an interesting space, South Africa, where we see how race reemergence or the reemergence of race as a topic, how it comes to the fore constantly. So when the news break that the first cases were reported in the Western Cape and in Cape Town, which used to be the epicenter, but now it's shifted to Johannesburg. It was very, in the public mind, it was phrased as a white affluent problem because the first connections were through international travel. And that had a very interesting results and consequences in terms of how things were phrased by the presidency, by ministers, by the public. And it had a kind of very similarity to thinking about health and disease in these specific terms. Now, in the South African context, we've experienced most of the other pandemics as well in various ways and in various time periods, but we have a long history of experiencing and being involved in the politics of HIV. There's also a lot of precarity, especially if you have to think about the amount of people that access African traditional practitioners. It's about 200,000 registered persons that deliver services in the university town of Stellenbosch, in the township of Kayamandi, which is still the predominant black township. There's only one government clinic. The rest of these spaces, people make use of traditional practitioners. And it might be naturalists or herbalists, and there's a whole range of different practitioners that people can access. And if the health belief system is so vastly different, and scientific explanations, it kind of gives us a contextual space to understand the complexity sometimes of disease. So this is one of the things that I kind of wanted to highlight, is some of the concerns and issues raised during this period. You know, I didn't want to do a full academic presentation. I would actually like to engage more and do conversations. There's a lot of things mentioned in the press as concerns, apart from corruption in the system. These are all valid concerns, and there's quite a lot of comparative content in this regard. So by just following the popular press, we are also very concerned about police of the population, and in particular, people still living in poverty and inequality, which is the majority of the population, and they happen to be Black. Our concern is that the military, about 70,000 or more, and police were very visible in these spaces and to control populations. And it's of key concern if we look at the reported incidents of police brutality and violence of the military, and how, in a way, kind of looking at what I said previously, this kind of foreign virus that has a particular understanding of a Western biomedical contextual understanding becomes kind of a symbol and a villain in a way for allowing things like brutality to happen, police brutality to happen. A lot of people have been arrested around breaking the rules and regulations, and sometimes it's not really well justified or backed up by science. One of the most contested concerns is that alcohol sales were permitted under a certain level of lockdown, and then it was withdrawn. And the reason why this is relevant in South Africa is because of the quadruple burden of disease. So we have a high level of infectious disease, then we have maternal and child health. It used to be a concern. There's a vast increase in that. But then then there's also personal injury, and which quite often is a result of violent communities, gender-based violence, gang violence, and traffic accidents, in which it directly correlates with the sales of alcohol, which is much higher over weekends. And so the incidences of people going to emergency rooms are is higher over the weekends, and it's impacting on the availability of health resources, which is not ideal at the time of the presence of a pandemic. Okay, so we've seen various implications around that, and the fourth burden of disease is lifestyle diseases, specifically diabetes, and we see as people move also into the middle class, irrespective of the inequality, how more people kind of have comorbidities as well, like infectious disease then, and also lifestyle diseases, so all the disease, diabetes, etc. So a lot of emphasis was placed on not selling cigarettes, and kind of if you look at the smoking and the direct correlation by science, it is not as significant as is the case in terms of other factors that play a role in increasing risk. And so there was a lot of questions around that, and then consistency. There's rumors, we don't know, but of vested interests in the illegal sale of cigarettes. And our current, one of our ministers who happened married to Jacob Zuma. Also then Zuma, she is employed already in being a figure and profiting from the illegal tobacco trade. So it's how we regulate, how the decisions that's been made, that has a huge impact and potential impact in the future of the economy. So a lot of money is put into resources. Some of these monies disappear as a result of corruption and kind of inconsistencies in the procurement of services. It seems as if some of the research data is faked or underreported in certain provinces. It has political dimension. That's another thing I mentioned. There seems to be the economic implications is vast. So by giving people some form of relief, but which is not substantial enough, through a social grant, so something like 300 Rand, translate a month, 380 Rand in addition, if you can translate it to US dollars, it's like nothing. It doesn't make a difference. But if you start multiplying it and you look at the 20 million plus people receiving that, the amounts become staggering. And it's money we do not have. Our economy hasn't grown as was projected. We are in a situation before COVID of state capture. So there's still ongoing court cases into this state capture and corruption of key government officials linked to some dominant Gupta families in India, etc. And millions. We are experiencing an energy crisis. So we sometimes have blackouts, we have load shedding, which is referred to as load shedding, which has a huge impact on the economy. It's been, and it's very precarious how certain arrangements are made with certain countries, and then suddenly during COVID-19, it happened a few times that we were under blackout experiences as well. We are concerned about the safety of our citizens, especially those living in close proximity, where there's more and more evidence of a public response and people getting hungry. So you don't want to impact on your health gains through creating a situation of hunger, because that's going to have an impact. People are concerned about, if we think about the prevalence of HIV/AIDS and how costly it is, it places a huge financial burden on the healthcare system, that a lot of the gains, and there's huge gains in this regard, of taking government and pharmaceutical companies to court so that people can have access to affordable drugs. So that is one concern, is that the system that was created made it possible for people to receive their medicines on certain days. There's kind of a social coherence and capital around going to the clinic, getting your meds, to adherence, but there's concern about the staff that would not be able to enter facilities, although alternative arrangements are made. It's inconsistent across different provinces of how those arrangements are dealt with. There's concern, we have comorbidity of HIV and TB, and if people do not have enough medicines, and also that community-based caring, those people in place, and the full system not functional, that tuberculosis could very well also just start reversing. We can, some literature indicate that we can be back to where we were in 2016 and lose all those gains. And it's very interesting how it might also be relevant in poorer resourced areas in the tuberculosis and how it might increase by not giving enough attention to pandemics. A lot of concern. There's now 2 drug studies to develop vaccines. I just heard about the one today. Still have to kind of look into that. And so that's at least a positive, but we are concerned about the cost and time and efforts that's being put into this, as opposed about the kind of long-term investment of knowing about the possibilities of these pandemics and not responding sufficiently in terms of resource allocation to what one can do about this. So the global risk report, various of those reports clearly indicated that one of the risks were the possibilities of the possibility of a pandemic of this kind. So it's all very interesting. So how much money do we spend versus the resources that we have to allocate now towards the development of a vaccine, which is complex, which can take long, but at least we have some studies happening. If I think about, okay, so there's many more implications on possibly on family life. What has been fantastic is that there's also opportunities in the sadness and the consequences of pandemics. And one of that is in our experience of the university system is that we very quickly reorganized. And what's been noted, and that's across social institutions, is that those people have been collaborating in the last few years, whether it's in a healthcare, or a few months, whether it's in a healthcare system, whether it's a teaching learning, that there's a sense of greater compassion and of people connecting to one another. This is considered to be very important for kind of thinking about the type of society we want to live in, the type of healthcare system that we want. So in South Africa, we've always been striving for an equitable, fair healthcare system. We've been worried about how are we going to deal with the political and economic power of the private healthcare system, where as a major challenge for healthcare in South Africa. We were worried about the burden of disease, which is quite unique in this part of the world, and in a country where inequality between people are one of the highest. We have in Johannesburg, Sandton on the one side, and we have some of the poorest people living in Soweto. You have the same in Cape Town. And with that kind of disparities, even within a township, there's vast differences. And also how people see themselves. So these are some of the concerns that we had before the pandemic also came to South Africa. If I can share with you, I can't share with you, but one information web portal is sacoronavirus.co.za. This is the official government portal. The government has been very good in distributing information, making resources available. We have a daily press release. The latest now is 11 August with country statistics. So it's sacoronavirus.co.za, HTTPS. And up to date, we have not done sufficient tests, according to some epidemiologists argue that following the Korean model would be ideal, is to have as many people tested. So we've conducted 3.2 million out of a population of about 58 million people. And we have 566,000, so you can work out the percentages of positive cases, and relatively a lower figure of death, 10,751. when we think about our healthcare workers, that's another thing to highlight. So the incidence of having COVID and the death mortality rate has been 5% of the healthcare service providers, being medical staff, but especially then those doing nursing services, etc., working directly on community level. And again, questions has been raised about the ethics of standards and the wearing of masks and following safety procedures. And again, with some of the tenders that's been provided, or the concern is that some of the quality of some of the materials that was made available to the healthcare system staff was of a low standard. Okay, so these are concerns. Our healthcare, I mean, one of the reasons why we struggle with health and not having an equitable system, apart from the inequality in the system, is that we had for many years a huge brain drain of trained academics or doctors, nurses, leaving the country to find employment elsewhere. You have to consider that South Africa does not have private universities, that all their universities are public funded. So we have a social responsibility towards our state to pay back. So we have, for example, in the final year of medical training, what was referred to as the Zuma year, because it was linked to Jacob Zuma and others, previous health minister, to have this kind of internship. But it's also, of course, part of professional academic training and the way things have been since people realized that the social determinants of health is also important, and that you have to train people sufficiently in this context. So what's been happening is we have this challenge of high mobility of people moving to work in different spaces. And again, those who are quite often quite well qualified are working in the private healthcare system. So the public healthcare system is quite often underserved, where you have young and excited professionals. It's been kind of quite a concern to see how people in the healthcare professions suffer from burnout. The Northwestern public health students and global health technology students can attest to what I shared with them. We always have these inspirational speakers in Johannesburg, you know, Black academic women being doctors, coming from a generation where the parents were domestic workers, you know, so they have beautiful stories. They are community leaders, they are inspirational. They have their own slot on a radio station, etc. And then the system kind of gets to them. And it happens 2, 3, 4 years. There's a lot of literature where that kind of thing is described, where you know what is in the best interest of your patients, but not even having basic medicines and stock outs and seeing the effect of that is kind of so demotivating, and even fuels those with the brightest fires in them to become disillusioned by the system. So it's really important that we learn through this process. So if there's, coming back to the previous point, if we think about a shift in thinking about institutions, we might consider, but what is the ideal, you know? And what does it mean, you know, to have a more equitable system? And what can we learn from others? So these are all kinds of things that comes to mind. While I can discuss probably many more topics or aspects of this, and my apology for not having a PowerPoint I sometimes think I don't want to do it like that. Let's talk. And yeah, so it makes one think of what can we learn through this. We might have a loss of thousands and thousands of people. When I looked at the history of previous pandemics in South Africa, I noted that how many people were lost their lives, but at the same time, that one directly resulted in people talking about a better public healthcare system. And it was actually the impetus that was needed to create the first policies around public healthcare. So from all of these pandemics, it brings us closer to hopefully where we want, irrespective of perhaps a shorter term loss and consequences. So there's also some kind of hope for change in the sadness of pandemics and going through that in a particular time. So I'm going to stop here. Is it okay, Sarah?
Yes, absolutely. Thank you, Jakob.
Yes.
Okay. So we do have a few questions. So if you'd be so kind to maybe comment on some of these topics, can you speak more about why the COVID data is being faked?
Yes, it has a political dimension, and there's still this mistrust in the biomedical, in science sometimes, because it's abstract. And if we look at statistics and how statistics are used, it's highly contested in various countries across the world. So which data do you trust? You have in South Africa, Statistics South Africa, which produce data, but they are state endorsed. Then you have the Medical Research Council. So we have the incidence of the very well-known academic who commented on some irregularities in terms of the lockdown restrictions and who backed up her argument with facts. And the health minister was very upset that this person could say certain things. For example, one of the things were that in one of the biggest hospitals in Johannesburg, we see an increase in child malnutrition. And this minister claimed that the information is wrong, but the Medical Research Council is reputable for presenting some of the best research data over many years, although they do have a connection to the apartheid years and the apartheid government, but as an institution they have been transformed. But still, there's this kind of lack of sophistication of, even if we think about the virology and epidemiology of viruses, where there's kind of, on a certain level, slight misinformation in the beginning in terms of how you get it, how you should be safe, etc. So we pick up on those. You pick up a lot on those inconsistencies at home, I guess. I'm constantly reading New York Times and other sources, so it's very interesting to also follow what's been happening in the US. But so that's one of the reasons. I mean, there's misinformation, there's vested interest, and sometimes there's amazingly, and I don't know why it's so important, democratic, bureaucratic processes of doing things in the right forums. If you're a member of a certain ministerial committee, you have to say what you want to say in that space. So if you say something in the press, the public arena, there's a lot of protection in terms of and justification for what government does, irrespective of evidence that is not always above board. So the statistical argument as well for reporting deaths and unknown, unaccountable cases. Again, someone from Medical Research Council said that it's evident that there's underreporting. And again, it depended on the amount of testing that was done in the beginning to indicate that, but the crisis, the epicenter is in Western Cape province, while we were ready to start with more comprehensive testing quite early. And now it's not the epicenter, it's now Johannesburg. And there's lots of issues around that. So statistics are really important, and how it's represented, because it says something about those responsible. And it wasn't in interest when there's a political party system where there's a lot of exclusion in the process. Of course, I haven't spoken about the fact that we didn't have a parliament in the last few months. So there's no oversight in terms of the constitutional rights of governance. So that's a key concern, but it's not necessarily my area. I don't want to speak so much about it, but a lot of concern around that. It's a small advisory board, which have some academics on it that make decisions. And there's apparently within these groupings, and it came out in the press in the last 2 weeks, a lot of inconsistencies as well, with some dominating public figures, kind of making the decisions. So decision making has been undemocratic, which will definitely not hold up in constitutional court. I hope that answered it. Sorry, it was a long-winded answer.
No worries. It just took me a second to unmute myself. That's all. Here's another one. So now you had mentioned, right, alcohol sales are now banned. Was there any consideration for implementing a per person quota on alcohol sales instead? And what has been the impact of this policy on South Africans with alcohol addictions?
So there's pros and cons to everything, and the key concern was exactly those with addiction, and if you define it not as not in a medicalized way, but as a real concern, then it's been highly problematic. So what is important in this kind of political, in the governance of COVID-19 in South Africa, and it was reiterated by the president a few times, is that there will be consistency. It doesn't help, and people are very politically sensitive for this, that certain guidelines are in place for certain people getting a quota by considering relative risk. Because what will happen is that people living in townships, and if you look at the high incidence accident rate as for part of the burden of disease, then it will be racialized because of where people live. So that was not considered linked to the burden of disease and the consequences and the impact on the availability of services. It was simply disregarded. The same argument is made with tobacco, because the argument is that people share cigarettes in informal spaces and when they gather socially, so it's a kind of social behavior around that, and that kind of impacts on proximity, etc. Whilst a larger part of the more affluent part of the population felt that is not fair towards them, etc., etc. But what the government has been very good with, it's exactly this, is to share like one policy fits all, although it's not necessarily a good thing. Because the implications in terms of what we refer to in popular terms of sin tax, but actually tax levied on alcohol and tobacco has a huge economic impact in terms of taxes collected and levies. There's a huge source of income for government, who then uses those funds to pay for the healthcare system, which is kind of a strange one, but quite a concern, weighing up risk for infection versus the economic and social impact of the pandemic. I hope that's, that's a useful answer as well. Yeah.
All right, great. And I think we've got time for one more. So I'm sorry, everyone. I know we did get quite a few questions, and I don't think we're going to have time for all of them. But I think this is a potentially relevant one to end on here. One of the big conversations happening in the US right now is about the return of university students to college campuses for in-person instruction and residential living, even as coronavirus cases are increasing uncontrollably around the country. Is there a similar conversation happening in South Africa? Yeah. How are things being handled there? And as a community engaged scholar, can you share your perspective on what implications these decisions have on the public purpose of higher education?
That's quite a long, that's another hour topic, but so what we've been doing is not to disrupt the academic program and to allow people to graduate. Those who are doing lab research, so there's a few selection, a certain proportion of students were allowed to return. It's also, which I think is good, is that a lot of people live in circumstances which is not conducive for academic work. They might receive a state grant, bursary, and doesn't really have the services to work from home. And they were also granted to come back to campus and to live residentially. So there's a plan and a process in plan. Students can also apply, and if they want to return, we saw the statistics. Only 16% of students actually replied to return. I think people realize the relative risk, and we had these issues debated vast, and especially pertaining to schools as well. I think it's a good time for us to pause and to rethink the purpose of higher education. We have such a lot of webinars and kind of resources and accessing ways of learning, looking at online materials. And whenever I engage my students, I'm currently still teaching a sociology first year class of 800 students. And not a lot of people decided to go away from campus. And we all kind of say to one another, oh, but we miss your physical presence. But I actually, at the same time, don't miss anything about being at the office, spending time in traffic, traveling, and I really love being at home. So in some way, it works for a lot of us, but I think there's no other place than being on a university campus. If you follow the debates and the articles in Times Higher Education, for example, it's really evident that there's been to be part of a network of living together, being in a residential setup. It definitely has its benefits, but we are in a phase of rethinking of redoing it. And it has ramifications for health and thinking about our future. Would we have, can I ask a question, would we have pandemics of this kind if we are kinder to the environment in terms of the way we use the resources, the traveling we do, etc. You know, so there might be positive and interesting ways that we can transform. And finally, going into what in the 21st century space. I'm so glad about some of the things that are now going to move fast. But it's amazing to see how people adapt, how it has had, for us that's a bit more privileged, I guess, kind of given us an opportunity to think about life, to relate different to people. I find online meetings to be highly productive. You have a recording of the meeting, you don't have to take notes necessarily. People are more to the point. So that's been a fantastic experience in that sense. You know, it's like, but it's also, of course, challenging in many other respects. Because what are the longer term effects of social isolation? and kind of thinking in terms of us as people not connecting in person.
All right, thank you so much. Well, and I just want to be mindful of time. It is 1:02, so I think that we we'll wrap it up here. So Jakob, thank you again so much for sharing your time and your expertise with all of us here today. So another round of applause for Jakob, or a virtual round of applause for Jakob. And to all of our attendees, thank you for joining us for this week's GLOVicariously webinar. Again, just as a reminder, these are weekly sessions, so please join us again to hear from another fantastic speaker next week on the topic of globalization and youth identity in post-war Vietnam. All right, and we will wrap it up there, so enjoy the rest of the day. Take care and thank you, everyone.